Good afternoon, everyone. We'll go ahead and get started. My name is Roshni Matthew, and I am one of the co-chairs of the COVID-19 in Children Seminar Series. I co-chair this with Dr. Alan Schroeder, and today's session is on COVID-19 and the primary care perspective. So we are very excited for our panelists and for the discussion that would follow this session. Our upcoming sessions are as on the screen. We have Dr. Bonnie Maldonado joining us next week for pediatric epidemiology and transmission. And then we have health disparities discussion with Dr. Huang and Dr. Powell the following week. And to claim CME credit, please go ahead and text the code as on the screen to the telephone number.
Dr. Braham. She is a pediatrician practicing at Menlo Clinic Pediatrics. She is actually one of our own, having completed her training at Stanford Children's Hospital way back in 2009. I have to say that was a little unsettling, Sabrina, to realize it was 11 years ago, because it just seems like it was a year or two ago. But no, it's been quite some time, and she has a really successful practice here, and also serves on a number of important advisory roles in the community. And we'll be talking about her and reflecting on her experiences trying to navigate this very challenging pandemic.
Thank you, Alan. I'm very happy to be here and share experiences. Certainly been a lot of it in the last 9 months. I'm one of 13 pediatricians in a large multi-specialty practice, largely adult. We're really the only pediatric department in Menlo Park. And our population is insured mainly, and we happen to be in network for Stanford Hospital employees, so we serve an important function with our local community, and in particular healthcare workers at Stanford Hospital. So today I'll be sharing my experience of COVID in ambulatory pediatrics, and keeping in mind Carol Dweck's principles of growth mindset, I'm hoping to create some space to reflect on opportunities for growth from the last few months of experience. So it's important to remember that back in February and March, we were in the throes of flu season. And it wasn't a particularly remarkable flu season. You can see it didn't reach the heights of 2017, 2018, although it was bi-peaked. But when you look at the pediatric numbers, actually, it was a particularly bad season for children. And by hospitalization rates, it was supposed to be one of the worst seasons in a decade. And behind that data is the important point to remember that kids are coming into their pediatrician with cough and fever during that time. And so there was a large volume of visits for influenza-like illnesses in the pediatric population, and significantly greater than adults during that time of year when COVID was reported in our neck of the woods. And remember, kids don't drive themselves to their pediatric visits. So with those pediatric bodies were at least one parent, maybe a sibling or two. And so in our particular setting, we can have up to 400 bodies in and out of our practice during a given day in flu season. So it's really quite a big infection control challenge, particularly so when we're talking about the potential for asymptomatic spread, which was the case with, is the case with COVID. So that's where we found ourselves in this setting in March of 2020. And we found ourselves in an immediate operational crisis, and also a very real threat to the health and safety of our staff, of our physicians, and felt very much to be the literal front line of the response, and needing to make sure that we could continue to serve our patients and protect ourselves at the same time. So what I've taken a picture of here is a triage that I scratched out after a phone call with Roshni, who made the mistake of giving me her cell phone number once when I was in training. But this was a triage, this was a major shift in our approach, both to nursing and physician workflow, that we were going to implement the very next day, which gives you a sense of how quickly things were moving. And we were fortunate because we have an exterior room, a rash room, that we were able to use as our effective COVID respiratory care clinic and not have patients come through our main entrance. And so we were able to remain open during March, April, May, when many other practices had to shut down. So you could best describe what happened as building a plane while flying. We had to make lots of critical decisions with very limited information. And that's typically not how medicine works. Outpatient decision making is typically based on evidence-based guidelines. And you probably have all heard that it takes 17 years for research to reach practice. So time was not in our favor. So what informed our decision making? Well, three things, I think, primarily. One, communication. So how can we leverage our resources? Two, collaboration, thinking that we are all in this together, supporting the inpatient community, supporting public health efforts, supporting our families. And then finally, and most importantly, actually, the clarification of values. And making sure that we kept in mind that safety came first. We had to make sure that our staff and physicians were safe and that we were still able to provide safe service to our patients. So needless to say, there were lots of barriers. Reviewing, tightening infection prevention and control measures, required knowledge of the pathogen, which was emerging at best. And then availing ourselves of testing. There was not much availability, as you recall, in the beginning, but not only that, accessing it for children in particular was challenging because you need a practitioner that's comfortable doing an NP swab in a child. And then PPE, everyone heard a lot about that in the healthcare community. Supply was an issue, but also getting a handle on supply chain so that we could plan to be open the very next day. If we don't know that we're going to have masks, we can't plan and take appointments. And then another piece that we hadn't really thought about is fit testing, right? So you could have a supply, but it may not be the N95s that you are fit tested for, and that added another layer of complication. And then really 90% of our energy expenditure was spent trying to what feels like move or turn this massive ship of administrative healthcare. Some of the administrative hurdles I'm listing here, but basically, you know, assimilation of the new data, things like learning that GI symptoms were common in kids and incorporating that into our triage, stopping nebs in the first week to make sure that we weren't aerosolizing the virus. To preserve PPE, we actually decided to do respiratory care clinic in the absence of any staff. It was just physicians so that we didn't have to use so much PPE. And then other issues that came up that were unanticipated, childcare closures had impacts for our patients, for our staff, and then general fear and discomfort among our staff, just feeling like you were at risk. So there were logistical issues around making sure that people felt safe. In terms of the resources that became useful, there were two particular articles, the 2007 report based from WHO based on the SARS experience, and then a more general document in the Journal of Pediatrics from 2017 talking just about IPC in the pediatric setting, both really helpful in working out all of these details in a short period of time. And then in late April, the IDSA came out with their guidelines, which essentially validated our approach and made us feel quite good about how we were doing. And since then, we've been operating our respiratory care clinic, and we introduced and ramped up telehealth and have now almost reached capacity with our well child visits since March without a single occupational exposure. So we're pretty proud of that. And now we're really just focused on the winter and flu season, and then trying to be proactive and have a sustainable approach to COVID going forward and then future pandemics. Thank you.
Thank you, Sabrina. It's funny hearing you mention Rajni because we've all been leaning on her within the hospital, where I think there's so much more infrastructure to help manage all of those issues that you had to deal with. So I really admire all of the general pediatricians who have had to kind of learn, put the plane together as you suggested. We're going to try to cover a number of topics relating to primary care, including the broad overview that Sabrina just presented, and then sort of talking about care at one of our FQHCs at Gardner and some of the challenges there. We'll talk about telehealth and how that's worked. And then we'll talk about some of the mental health issues that have plagued really our teenagers and how that's manifested in the primary care setting. And then circle back with some lessons learned. And then we'll squeeze in that presentation that we had originally planned for by Dr. Petra at the beginning. So without further ado, Dr. Kakar, if you can start sharing your screen. Dr. Kakar is a board certified pediatrician in our division of general pediatrics. She's also a certified lactation counselor. She has her primary practice at Gardner, and she's involved in a number of local and regional initiatives around expanding access to breastfeeding support, promoting childhood nutrition, and creating frameworks in pediatrics for telemedicine, and does a number of advocacy efforts as well, including some important work with the American Academy of Pediatrics and their section on breastfeeding. So thank you, Dr. Kakar.
Thank you so much, Alan, for that introduction. And it's a pleasure to be able to speak today from the perspective of pediatric primary care in lower resource settings. So to set the stage, our clinic serves as a safety net for over 3,500 children of families living in the Mid-Peninsula, and is the primary community clinic site for Stanford Pediatric residents and medical students. Our mission is to serve the comprehensive health needs of vulnerable populations in our community. And this is just a snapshot of some of the medical conditions as well as social determinants of health, which we evaluate for and address at each visit. Knowing the disproportionate impacts of COVID-19 on communities of color, underrepresented minorities, and children with special healthcare needs, we had a tremendous task ahead of us to adapt our practice and better serve our patients and families through this pandemic. This represents a timeline of our practice through the beginning of the pandemic. At the onset in March, we needed to rapidly evolve to prioritize safety for our patients and families, and we successfully transitioned to telehealth for the majority of visits within a 2 to 3 week period. By May, 70% of our visits were done via telehealth, including modified health supervision visits. With the exacerbation of emotional and behavioral health concerns during the pandemic, and anticipating further disparities created by virtual learning modalities, we transitioned to telemental services as well as established telehealth developmental behavioral consults. And throughout this process, we were really fortunate to be able to retain our commitment, not only to our patients and families, but also educating trainees and medical students who have all remarkably stepped up to advocate for patients and families and adapt to frequent changes in workflows. So moving forward, the main points that I wanted to delve into further today are revolving around ongoing recovery of well child and vaccination visits, strengthening support of newborns and breastfeeding mothers, and the importance of community advocacy. In the second week of May, the CDC Morbidity and Mortality Weekly Report examined data from the Vaccines for Children provider order data. And as background, VFC is the national program which provides federally purchased vaccines for children up to age 18. And this is the primary source of vaccines for an FQHC. The vaccine tracking system data indicated a notable decrease in orders for VFC-funded non-influenza childhood vaccines, as we can see in the solid line here, as well as measles-containing vaccines in the dashed line. It's clear that the decline began the week after the national emergency declaration in mid-March and continues to plummet through the second week of April. The ongoing pandemic underscores the importance of recovering childhood vaccination rates to prevent outbreaks of vaccine-preventable diseases, and in the case of upcoming flu season, avoiding twindemics. So what do we do to provide ongoing health maintenance as pediatricians? A lot of this comes from interim guidance issued by the American Academy of Pediatrics, and I'm not going to spend as much time on the first 2 points here, but I'm going to spend a little bit more time going through why it's important to outreach and have close follow-up with our most vulnerable pediatric populations. And this involves medical as well as social complexity. So there is limited evidence around risk factors in children to develop severe manifestations of SARS-CoV-2, but it's still beneficial to conduct specific outreach to children who have conditions such as obesity, which we have been seeing increases in, medical complexity, asthma, and other chronic lung diseases, and those patients who may be on immunosuppression. And the second piece of this is the social complexity part. So children who are struggling with virtual learning may have already had a history of learning disabilities, ADHD, special educational needs. There's been an exacerbation in providing services to children who have existing mental health disorders. And we know the impact and the stressors that our parents and caregivers are going through during this time. So reaching out to families who have known social stressors such as food or housing insecurity. And now focusing on newborns and mother-infant dyads. So just to review some of the evidence around SARS-CoV-2 in this particular population, initial American Academy of Pediatrics, as well as CDC guidance provided in early April, recommended temporary separation of newborns from infected mothers. And at that point, there was limited data around perinatal risks of disease. And since then, multiple national as well as international studies have proved that, yet so far, there haven't been any published reports that have identified infant mortality during birth hospitalization as a result of SARS-CoV-2. Among over 3,000 mother-infant dyads in the National Perinatal COVID-19 Registry, we found that the likelihood that an infant has a positive PCR test is similar for infants separated from mothers versus infants who were rooming in with their mothers using appropriate infection prevention practices. Several studies have also been looking at trying to detect SARS-CoV-2 nucleic acids in human milk. However, so far, no viable infectious virus has been detected, and pasteurization methods, which we use for banked donor milk, have also been shown to inactivate SARS-CoV-2. And there's a lot of work to be done in this area, so we still don't know whether protective antibodies against SARS-CoV-2 are found in human milk. However, from decades of research, we do know that human milk has a plethora of immunoprotective factors, and breastfed infants are less likely to develop other viral infections. It is also well recognized that in addition to other maternal and infant health benefits, breastfeeding promotes maternal well-being, reduces risk for postpartum depression, and is sustainable during the time of emergency. And as we saw early in the pandemic, there were several weeks where it was difficult for families to find formula. So how do we promote and support breastfeeding as pediatricians? The approaches, as I've alluded to, begin from the birth hospitalization, and many of us in outpatient pediatrics also practice in the newborn nursery. So the main points are, of course, to try to avoid separation of mother and infant and ensure safe skin-to-skin practices after birth, because this lays a strong foundation for that breastfeeding relationship within the first 24 to 48 hours. It is also crucial to have adequate lactation support prior to discharge, particularly for mothers who have tested are PCR positive for COVID-2 and need to know how to safely breastfeed or be able to hand express or use a pump to have an alternate caregiver expressed milk. Now, this support extends to the outpatient clinic. So through this pandemic, unfortunately, various clinical policies have limited mothers with confirmed PCR positive SARS-CoV-2 from being in the clinic environment. Alternate caregivers may be bringing in the infant for necessary exams and weight checks, but it's still imperative to evaluate for breastfeeding difficulties because these first few weeks are critical to establishing mother's milk supply. Having knowledge of the basic clinical management of breastfeeding allows pediatricians to evaluate mother-infant dyad and particularly focus on risk factors that may require readmission for newborns, such as poor weight gain, dehydration, and jaundice. Telehealth modalities is a great way to be able to support this particular population. The other important piece of this, when we're not actually physically seeing mothers in clinic, is to be able to assess maternal social supports and well-being, as well as screening for postpartum depression, particularly during this stressful time. Now we move into the community, and the best we have around initiation of breastfeeding, as well as supporting mothers in being able to exclusively breastfeed through the first 6 months, particularly in groups that are at higher risk for early breastfeeding failure, is for providing peer support in the community. And that's someone who speaks the same language and has overcome the same barriers as the mother. So partnering with organizations such as WIC, La Leche League, and local breastfeeding support groups is so important to establish wraparound services. And this speaks to our ongoing work in community engaged solutions and partnerships with WIC, whereby we send electronic referrals and get mothers peer partner support. And then other ways have truly revolved around our pediatric advocacy program here at Stanford, which early on in the pandemic was able to establish COVID-19 county-specific community resources around food, housing, legal aid with eviction notices, and distance learning help. At our clinic, every family received a flyer with their health visits via telehealth and by mail. The Pediatric Advocacy Program also organized family food bag donations, diapers at the doctor programs, and a main piece of this is the Impact Coalition, which is pediatricians and allied health professionals, including school professionals, and really aims to continue to address social determinants of health for families through this pandemic, as well as fostering resilience. Thank you.
A really nice talk, Pooja. Thank you so much. And folks, please put questions in the Q&A. We will hopefully have some time at the end to address those. I'm assuming there are a lot of questions about breastfeeding and COVID positive moms. So Chethan Sarabu is a general pediatrician here who has a focus on designing technology that empowers patients and families to better participate in their care. He did his pediatrics residency at Rutgers and went on to do a clinical informatics fellowship here at Stanford, and where he helped to deploy and expand open notes. He finished that in 2018 and is now director of clinical informatics at Doc AI, which is a digital health startup. And he also works at Gardner as a general pediatrician and continues to work with the clinical informatics fellowship as well. Thank you so much for joining us today.
Thank you so much for the introduction and for having me today. So to transition from where Dr. Kakar left off, I'm also a general pediatrician at Gardner and wanted to dive a bit more deeper into telehealth for primary care. I also do work at Doc AI, which is a startup, but my presentation today has no relation to that work. I wanted to start with this image, which was created by a medical student, Ryan. Telehealth has this massive potential to really link clinics with broader community and to deepen our context and understanding. We often think about the computer screen as a barrier between communication between physician, healthcare professional, and patients and families, and it might be the case. But with telehealth, there is this interesting opportunity where technology allows us to have a window into a patient or family's life that we might not otherwise have, to actually be invited into their home. And as I put this together, I was thinking about a couple of different patient encounters I had where this was very powerful in ways I didn't even anticipate. I was doing a well child visit with a 12-year-old who was struggling with his school, as well as a number of other challenges. And during the visit, about every 4 minutes, we could hear the Caltrain in the background. And he lived in an area of such noise pollution that it was extremely difficult to concentrate. If that visit happened in clinic, I would not have known about that, would not even have asked about it. But by doing a telehealth visit, there was immediately a much richer context of understanding of what this child and family's home setting and life is like. So there's a lot of potential to really make that connection. So there are many benefits that such as the convenience and access to patients and families where they don't have to travel, the cost of travel, the stress of travel, the ability to have visits in the home is powerful to be able to understand context. And there's also the opportunity to have increased longitudinal engagement. Instead of coming in for an annual visit, telehealth makes it easier to have more check-ins more frequently. But at the same time, there are also a lot of risks. Not all evaluations can be done over a virtual visit, can't do physical exams as easily. And there are also other challenges, such as potential delays in evaluation if the appropriate technology is not used. There's also considerations and challenges around privacy, where a patient might not have the space to talk about something that could be more sensitive while they're at home. So in addition, there's also a lot of considerations that are needed. Patients and families need to have access to high-speed internet, need to be some level of technologically literate, have these base considerations. And for clinics as well, need equipment. Many computers that we use in clinics don't have webcams, so most places have had to adapt with using cell phones or laptops. There are also additional challenges, for example, at Gardner being in a teaching clinic, that coordination between when a resident might call and speak to a family over a virtual visit, then you'd have to have the family wait while the resident presents the case to the attending, and then back to the family. So there's additional challenges that come with adapting a teaching clinic to telehealth, as well as bringing on additional services like interpreter services. There have been a number of great solutions and adaptations that are starting to happen. Many companies which provide internet and Wi-Fi have started to provide lower cost internet, greater access to public Wi-Fi. There's still much more work to be done. We know there are great inequities in this space. Organizations like WIC that Pooja had mentioned have been starting to adapt to telehealth models where a lot of the traditional in-person screening that needed to happen can now happen virtually. And it's an area of rapidly evolving literature. There are a number of articles that have been coming out across multiple journals that are really looking at telehealth in pediatrics. There's still a lot of work to be done in understanding how to best adopt the space. There's an organization, a subgroup of the American Academy of Pediatrics called Sprout, that is particularly looking at how to measure the effectiveness of telemedicine. And that is going to be important for determining new payment models, new clinical guidance models. But really, it's been a rapid adoption this year with the COVID-19 pandemic. And so with the rapid change, a lot of our work has had to be adapting practice guidelines in places where there's little to scant evidence. So without the evidence-based guidelines of how to do a primary care asthma telehealth visit or how frequently these visits should have to happen, we have started to really let practice-based evidence guide the way. And Dr. Kakar and myself have started to put this together in a website. This link for it is below the pediatric telehealth website, where we started to share some of these guidelines. And we have also created guidelines for well visits that help explain what could be done in the virtual component of a visit, how to conduct a virtual physical exam. So this might be an interesting resource for some of you. It's still an evolving area of growth. And really to kind of close, I wanted to just go a little bit deeper into what a hybrid well-child visit could look like. Many places have started to do this. There is some things that need to happen in person, screening measurements, physical exam, immunizations, but a lot of what we do can also be adapted to be virtual. The conversations around anticipatory guidance, around many concerns, surveys could be remote. So we're really entering this new space, but we really need payment and practice models to adapt. And just one final thought to close on, there's a lot of interest around how home-based measurement can also be used with telehealth visits. And it's definitely a promising area, but there's also a lot of challenging considerations. If measurements of height or weight are taken at home, how accurate are those? If we enter those into the electronic health record, there's also a concern of potentially overemphasizing certain measurements, particularly concerns with weight and eating disorders. And you're going to hear more about that in the next presentation. There's also a lot of issues around costs. To purchase an automated pediatric blood pressure cuff for home, the cheapest one that I know of and others have known of is nearly $80, whereas adult automated cuffs are much cheaper. There are also newer tech devices coming out that allow parents to do full physical exams over virtual telehealth visits. And these are promising, but there's a lot of concerns around how equitably they will be shared. So it's a rapidly evolving area of telehealth, and stay tuned for more in this domain. Thank you.
So fascinating to think how this pandemic will transform the future of telehealth. Thank you for sharing all of that. So next up, if you can start sharing your screen, Dr. Juvvadi. Dr. Juvvadi is the lead physician at Juvvadi Pediatrics, which is part of Stanford Children's Health in Mountain View. She's been in practice there since 2001. She is the former medical director of our urgent care and is involved also in some global health based projects in Ethiopia. And I will add that she gave us a terrific grand rounds on some of the mental health issues facing our adolescent patients back in the spring. So looking forward to this talk. Thank you, Anita.
Thank you so much, Alan. I appreciate it. Thank you guys for making time for us during lunch. So I wanted to talk specifically about eating disorders during this pandemic. So while other mental stressors have been exacerbated, anxiety and depression are understandably worse during the pandemic, we're definitely seeing also an increase in eating disorders across the world. I wanted to briefly do a case study. This was one of my patients that, presented a month ago, a 15-year-old with a 6-month history of amenorrhea, constipation, and weight loss. So at the beginning of the pandemic in March, the entire family went on a so-called cleanse. They stopped eating meat and processed foods. They were eating more vegetables. They started working out more. They had zero social contact. Both parents lost 20 plus pounds each, and the child started to lose weight too. And interestingly, the parents were lauding her for it, and they were quite proud of the fact that she too was losing weight. And at home, they were doing workout videos every day for an hour. And then she was following that with running as well. And so there is a family history. Dad is extremely anxious. He was paranoid about any COVID exposure. And over time, the child too started getting more and more anxious. So she presented to me about a month ago with a 24-pound weight loss over 6 months. She was cachectic. Her heart rate was down to 39. So I had to admit her for malnutrition to the peds general unit, and then she got transferred to the ED unit when a bed was available. But this is fairly typical of what we're hearing in our patients. In the last 5 months, we've definitely been seeing an increase in health concerns, mental health concerns, but particularly eating disorders. And our Bay Area counselors and therapists that I reached out to similarly were reporting about an 80% increase in calls for help. And they were adding more hours. They were trying to bring in partners. They were trying to increase their telehealth presence to accommodate for this sudden increase in need. This was a neat study that I saw. It was published by the School of Social Work from Colorado State University. They questioned about 183 families that had kids under the age of 18, and you can see about 35% of them had lost their income. 16% were stressed about being unable to socialize. 17% said they were stressed. 15% they said they had difficulty managing their children's academics. So when the parents themselves are struggling, unfortunately, our adolescents are feeling the stress even more keenly. And it's no wonder that a lot of them are saying, my parents didn't even notice that I was eating more or less, exercising more, that I was stressed and anxious. And so when the parents are not available to, mentally available to notice what our adolescents are going through, it's understandably adding a layer of stress there too. In a Chinese survey, this one was actually during the peak of the pandemic in April and May. They surveyed about 8,000 adolescents, and they too reported a 43% increase in depression, a 37% increase in anxiety, and a 31% increase in both anxiety and depression. And specifically, our eating disorders have definitely been on the rise nationwide. What's new, what we're seeing new, is there's a sharp increase in younger kids that are presenting, the 9 to 11-year-olds. A lot of this is from social isolation and increased time spent on social media, improper food habits because of restricted grocery shopping, hoarding that we saw in the beginning of the pandemic, where parents were buying more and more non-perishable items and stocking up. And of course, the loss of normal routines where they were not going out to get any physical activity, and of course, being afraid of gaining weight and getting fat. Our adolescents trying really hard to establish control, and their way of controlling is controlling their diet, their exercise, and taking supplements like laxatives, and reading labels, and just trying in any way to have some sense of control. The Eating Disorders Resource Center in Silicon Valley, which by the way is an amazing resource to tap into, they've reported an 80% increase in newly diagnosed eating disorders. And similarly, NIDA is reporting a 70 to 80% increase in requests for information between March and August. There was a survey that was that I saw in the International Journal of Eating Disorders. They found that families that were previously diagnosed with anorexia, or children and adolescents that were diagnosed previously, there was a significant increase in both anorexia symptoms and a 35% increase of binge eating episodes. And this is putting a huge strain on our resources. They're unable to get in to see their usual therapists. And if they do get in, the wait times have increased. They have limited access to virtual classes or therapy. And like Pooja and Chethan indicated, we're trying really hard to provide these services, but some of our adolescents are really hesitant to take these classes or group classes virtually, or even connect with us virtually, because they're not able to find a safe space to sit down and or have the privacy to connect with us. And if you look at the how a pandemic can affect these adolescents, there's increased risk with media exposure and disruption to their daily activities and social isolation, as we talked about, and the modified physical activity and modified sleep. They're all sleeping late and getting up late. The negative affect of just having everybody around you be pessimistic about how the pandemic is progressing and how we're not having a sense of control, or how our government is not able to deal with this pandemic effectively. And the fear of contagion. And then you add in there lower access to care, the lack of social support, the emotional dysregulation that our adolescents have when there's a stressful event, and having very poor access to treatment and care. And you have this perfect storm for having an increased risk of eating disorders. There was a nice study that was presented at the Journal of Eating Disorders. They reported about 129 patients with previously diagnosed eating disorders, and you can see about 85% of them felt worse. Really, nobody felt better. And I wanted to spend a few minutes reviewing this article that I thought was very elegantly presented, and it kind of reflected what we're seeing in the community. It was a study of 159 patients, young adults and adolescents, who have been diagnosed with anorexia in the past. It is a small cohort, but kind of reflects what we're seeing. And you can see about 56% of this 159 were studying from home, whether it was homeschooling or going to university online. And you can see about 40% of them had worsening of their symptoms, and about 20% had new onset symptoms, and about 50% had worsening quality of life, and 30% had impairment of therapy or were unable to reach their therapist. And if you take a look at what their symptoms or their concerns were, 65% of them were concerned about wanting to be thin or the drive to be thin. 70% worried about gaining weight. But what was interesting was at the bottom of this column here, a sense of control. 55% of kids said that the eating disorder gave me a sense of control. And look at the bottom number, it's 60% said that it makes me feel safe. So it's quite concerning that, at a time when we're unable to provide the mental support for our teenagers, this is what's giving them a sense of safety. The majority of them were restrictive eating, some binge eating, laxative use, weighing yourself over and over again, the hoarding, as you can see, about 20%. And if you go further down, skipping meals, relatively common, and we are certainly seeing that in the community. A lot of our kids are sleeping in and skipping breakfast. That seems to be something that's consistent across the board with a lot of our adolescents. A lot of them are working out more. So 63% of them, as you can see, are doing more home workouts, which interestingly was something I have been recommending this whole time. But you can imagine if a stressed or anxious child is trying to do these home workout videos and there is no checks and balances in place, it's very easy to kind of go overboard and go into an unhealthy workout routine. So I'm sorry I had to breeze through those slides, but in summary, we definitely have an unprecedented increase in eating disorders with our kids, with our adolescents trying to establish a sense of control. And while we hope that while a phased return to school will help them, at least providing that social support that they're needing, we hope to see a slightly lower number of cases that are showing up. Things that we want, what can we do? Things that we'd like for you to be aware, be vigilant, ask questions specifically about shopping and eating habits, reminding our families to shop healthy, not by reading labels, but go look at colors. What color vegetables are we buying this week? Reminding parents to not discuss their own weight challenges with children. I'm consistently hearing parents sitting in the room going, oh my gosh, I'm so fat, I've gained weight, all my friends have gained weight. Your adolescent child really does not need to hear that. And instead focus on movement and fresh foods, trying to discourage buying and hoarding non-perishable foods, and how to encourage nutritional eating, looking for signs of self-harm, and really spending more time at our well-child visits reviewing mental health. And if we're unable to get our teens in for annual physicals during the winter, at least consider having an RN or a nurse practitioner do virtual visits. And then unlike, I know Chethan mentioned, having scales at home, and like he was hinting, we really don't want to overemphasize checking weights. And in fact, I would limit access to the home scale and only do supervised weight checks with the parent as directed by the PCP or by the eating disorders clinic, whether it's weekly or biweekly. And perhaps consider restricting access to some of these adolescents to their smartwatches and Fitbits. Of course, you don't have to restrict all the children, but at least the ones that seem to be at high risk. Ask about soft clues like amenorrhea or a sudden increase or duration of intensity of workout or constipation. And these workout packs or challenges, this is something I have been encouraging my adolescents, the ones that have been relatively sedentary. I'm like, try to find a friend and make a pact or have a push-up challenge or do a group relay marathon. But being mindful of the motivating factors. Why are we doing these challenges? Is it because you want to lose weight or if you just want to stay healthy? Restricting access and avoid discussing the calorie content of foods. And then getting familiar with our admission criteria. What is it that we should be a little bit more watchful for? That drop in pulse rate when you're doing orthostatics, or the change in weight over time. And then considering alternative approaches to admission, because our adolescent units have been stretched to the limit. So trying to find a creative way of admitting if the patient does need inpatient care. Familiarizing yourself with some local resources. This is just a very partial list, but besides the Eating Disorders Clinic at Stanford, NEDA and EDRC are very, very helpful. Even if you are kind of strapped and don't know where to send your patient, they're very helpful in helping you find resources and getting the kids plugged in to virtual discussion groups. Some of these are private entities. They do offer inpatient care as well as outpatient care. But I think the bottom line is know what you're looking for, be vigilant. I know we don't have time for doing physicals for our older patients, but trying to be mindful of their mental health needs during this time. Thank you very much.
Wow, well, that was both important and sobering. Thank you, Anita. Sabrina, I think you were going to try to bring us home with some closing thoughts, and then we'll hopefully have a few minutes left after that for Q&A.
So I can hear my kids rolling their eyes as I say this, but what can we learn from this experience? I think our first lesson could be that we need to learn from it. Reports and studies from previous outbreaks make it clear that we haven't done enough really to be prepared. And so there is a ways to go. In reviewing the literature on prior pandemics and reflecting on our experience with SARS-CoV, communication and collaboration were cited as major barriers to an effective response. And in my experience, that tends to fall into three different buckets. The first one being obviously patient-centered communication, leveraging the gains that we've made in digital health during the pandemic to really maximize the potential of its use, both in future pandemics and outside of those. And then ensuring that there is some two-way communication structure to facilitate collaboration between the various stakeholders, ambulatory, inpatient, academic, and public health agencies, so that all players can pull together as a team. And so the idea of maybe a regional response team, something that includes all the stakeholders in a two-way conversation. And then finally, creating really flexible and nimble internal communication frameworks. So within organizations, email, text, fax, sort of the typical way that we're communicating even via EMR. And those are really outdated when you need to communicate rapidly and in information silos. So considering newer modes of communication like Slack, to name one. And then finally, thinking about ambulatory care as really the first front line and using them as a mode of surveillance and first mode of response to emergency situations. In that vein, I wanted just to call your attention to an interesting study in the October issue of the Journal of Pediatrics. It's a retrospective electronic medical record data analysis that looked at January through March of 2020 in 15 states and then compared to primary years. And what they found is that there was an increase in non-flu influenza-like illness visits compared to prior seasons. And they posed the question, can we use ambulatory visits as an early warning tool? And I think it's an important question to ask ourselves, what are the other ways that we can really use our ambulatory clinics that are seeing all the kids with cough, fever, to help us prepare. So I do also think that it's important that we take an opportunity to recommit and review our values as pediatricians and advocates for children and for families. A lot was learned, I think, in the last 9 months. And in particular, when we think about the values, the first one that comes to mind is really staff safety. So making sure that our infection prevention and control protocols are robust and able to flex for different types of pathogens, ensuring our PPE supply chain is clear and that we have fit testing provisions so that all of our staff and physicians are well protected. And then obviously, as my colleagues have discussed, ensuring that we have ways to continue care, routine pediatric care. So obviously a rigorous pandemic response plan, making sure that we have capacity for surges, and then preserving access to routine care, whether it's in person or via digital health. And then finally, I think it's important to think about our role as community leaders and advocates, because many of you know there was an existing childcare crisis prior to the pandemic where access and affordability of childcare was already a problem. And we saw lots of childcare facilities closing due to the burden of infection control, fear of infection and so on, or just the economic challenge of ratcheting up their hygiene practices. And so it's likely to compound our existing childcare problem. So how can we as pediatricians support our communities and the childcare organizations that provide essential family services, partnering with childcare programs to provide infection prevention and control guidance. Pooja talked a little bit about our role in food insecurity, super important. And then there's the organization Vera Cloud Testing out of Stanford that has created a scalable, affordable, low-cost testing for at-risk communities. And if I'm not mistaken, I think they partnered with the LA County School District to provide testing. And it's partnerships like that I think can make a significant impact in getting our kids back to school safely, making sure that our teachers feel safe, and really ensuring the ongoing health and safety of our families. And then I just wanted to finish with really a beautiful narrative of an ambulatory medical team at their best during a crisis. And so if you'll just bear with me, I'll just read. We must recognize that medical care exists on an ever-changing continuum between the inpatient and outpatient settings, and stay flexible enough to enhance the care in one setting without abandoning the other. We must preserve the spirit of innovation, the collaboration across silos, and the sense of urgency, and model this for our trainees. Thank you.
That's a great quote to end on. And actually, I know there was a question about breastfeeding in the Q&A that we'll try to get to in a second, but I want to just ask you guys, being on the, maybe you guys can all get back on your videos, being on the front line, lack of PPE at the beginning, so much uncertainty, reading about colleagues around the country getting sick and some of them passing away. What has been the toll on you and your colleagues from a mental health perspective? We talked about mental health in our patients, but what about us? How was that, and how have you continued to manage it? Maybe Sabrina, I'll pick on you first since you just concluded.
Yeah, I think I could do a whole talk on that. But I think it's been significant. I think, what I experienced in my colleagues, both staff and physicians, is that we come to this career with an orientation to help. And so the instinct is I'll reuse my PPE. We used our same masks, I think, for 3 or 4 weeks before we got new ones. And so the instinct is to put yourself in the line of fire. And I think that's noble and wonderful, but it shouldn't be an expectation of the job. And so that's really where my call to make sure that our supply chains are addressed comes from. But yeah, I think, I don't know if anyone's familiar with this SCARF model of interpersonal interactions in the workplace, but it describes how there are basic requirements for good interpersonal interactions in the workplace, and one of them is certainty. Another is autonomy, and so on. And in a situation where all the certainty is gone, and really you don't know if you'll stay healthy or bring a disease home to your kids, I think it's impossible to overstate how impactful that was on all of us.
Yeah, thank you. Anyone else want to share their thoughts?
Really important points that you raised there, Sabrina. I also wanted to add that thinking about other healthcare staff besides us physicians that are on the front lines, they are also in the community, and many of them come from communities of color and ethnic and racial minorities. So they were already at greater risk for getting COVID. And so I think there's also work to be done in the area to make sure that all of us, regardless of where we practice, have equitable access to appropriate PPE.
Alan, I was just going to add that, in the beginning of the pandemic, I think we were all overwhelmed with all the constantly changing recommendations, and it was a sense of not being in control, which is really difficult for a lot of us who are planners and we like to plan everything. But I think somewhere along the way, we had to say, okay, you know what, I need to take care of myself too and take care of my family too. And I think that was a hard lesson for a lot of us because like Sabrina said, a lot of us come with a noble intent and we don't think of ourselves. And so putting ourselves up front was another big challenge for a lot of us.
Thank you. I want to just make sure we get this question. I think this is largely going to be, well, this really could be both Pooja, this could be all of you, but I think it's a combination of talking about breastfeeding and telemedicine. Lactation counseling is very tactile. And how are we able to adapt to doing that with telemedicine?
I can take this first. That's a great question because lactation counseling is very hands-on, particularly around like latching and showing mothers how to hand express and connect to a pump, as well as being able to assess for infant oral motor concerns like ankyloglasia. But we were able to adapt very quickly, being able to use models to be able to demonstrate some of these techniques. Other strategies that can also help include having an adult helper help mom use a mobile device during the visit for the video visit. And then it's also helpful if parents have access to a low cost scale or food scale, but you'd be surprised how much can be done over telehealth. And I'll let Chethan continue there.
Yeah, I think one of the things that struck me through this is by using telehealth, we have to be able to explain procedures, for example, things that we might be doing in a physical exam that we in person might do without necessarily explaining every single step of what we're doing. But by doing it over telemedicine, you're often having a patient or family member try to do procedures, exam maneuvers on their own. And so there's a level of explanation. And I think it's a really great educational opportunity. Having a child assessing dehydration, if you're asking a parent to check for capillary refill by pressing on the nails, instead of just viewing that as a passive observer, I think there's a level of education that also happens with patients and families as they're asked to take part in the physical exam a bit more. And so I think that's an interesting aspect of this to consider as well.
Well, guys, it's a little bit after the hour, so we're going to have to wrap up, but I learned a ton and I really appreciate all the work you guys are doing out in the community. Thank you so much for that and for your great talks today. Thanks everyone for joining us. See you next week.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.